to Continuous Cardiac Education. Today we'll be discussing conduits in CABG. I am Dr. Alay Parekh, Assistant Professor in Cvts Department at UNMICRC Institute of Cardiology and Research Center. So let us go to the history. CABG is one of the most common operation performing cardiac surgery. It has gone through remarkable changes over time. In the initial era in 1960s, there was the experimental work. The second era was from 60s to 90s, where different graft and evidence-based medicine was practiced. The current era is of minimal invasive and hybrid revascularization. Let us give all the credit to Alex Carroll, who described coronary circulation in 1910 and performed intrathoracic aortic and cardiac anastomosis in dogs. Claude Beck in 1935 placed muscle pedicle, omentum and pericardial fat inside the pericardial cavity to increase myocardial blood supply. Windberg performed the Windberg procedure, where the lemma was harvested and implanted into the left ventricular wall. Charles Bailey performed coronary aneuploidy. In 1960, Robert Gauss performed the first CABG, where anastomosed the lemma to right coronary artery using Rosneck or tantalum rings. Here, metal rings are placed over the vessel and the vessel wall is everted over it, and the two metal clips are again joined to each other. This was the old technique first initiated by Robert Gauss to perform CABG. Sebusen performed the first hand-sewn anastomosis, where anastomosed vein to right coronary artery. Kolesov performed lemma to RC anastomosis in 1964. Dr. George Green at New York City performed the first lemma to valid anastomosis, which is the gold standard in CABG. It started the new era of CABG. And as we know, Fowlerov performed the first series of CABG with excellent outcomes and gave birth to the modern coronary surgery. So we have the arterial conduits. Here is the list. Autologous conduits: the internal mammary artery, right and left; the radial artery, inferior epigastric, splenic, gastroduodenal, left gastric, intercostal. These all are the have been performed over time, but internal mammary artery and the radial artery are the commonly used arteries. For non-autologous, we have the bovine internal thoracic artery. Venous conduits: autologous is a great saphenous vein. Rarely the short saphenous or cephalic or basilic vein are used. And non-autologous conduits, we have the umbilical vein or the great saphenous vein homograft. With the synthetic conduits like PTFE, Dacron or tissue engineered graft. So before we jump into the conduits, let us have a look at the histology of a blood vessel. So the inner lining is intima, lined by the endothelial cells, followed by the internal elastic lamina. This internal elastic lamina has multiple fenestrations which allow passage of nutrients and metabolic waste. The second is a tunica media. It contains the smooth muscle cell, and it is bounded by the external elastic lamina. The last layer is the adventitia, which contains the vasa vasorum and nervi vasorum. So internal thoracic artery. So internal thoracic artery origins about 2.5 centimeter medial from the clavicle, below and opposite to the thyrocervical trunk, and it courses downwards about 1 centimeter lateral to the costal margin up to 6 costal cartilages, and here it divides into the superior epigastric and the muscular phrenic artery. Relationship: if you see the relationship, anteriorly the lemma is lined by the medial end of the clavicle, the internal jugular vein, the brachiocephalic vein. There is phrenic nerve passing along with it, fibers of pectoralis major muscle, upper 6 costal cartilages, and the internal and external intercostal muscles, and along with the upper 6 intercostal nerves. If you see posteriorly, above the second cartilage, it is related to endothoracic fascia. Below the second costal cartilage, it is related to the sternocostallis muscle, which intervenes between the artery and endothoracic fascia and pleura. The internal mammary artery is escorted by two vena committents, which unify the level of third intercostal cartilage to create the internal thoracic or mammary vein, which runs upwards along the medial side of the artery to terminate into the brachiocephalic vein at the root of neck. If you see the branches, it gives a pericardiophrenic branch which originates at the root of the neck above the first costal cartilage, and it descends along with the phrenic nerve up till the diaphragm. It supplies the pericardium and the pleura. It gives multiple small inconsistent mediastinal branches which supply the connective tissue, thymus, and the front aspect of the pericardium. It gives enterintercostal arteries. There are 2 each for the upper 6 costal space. The perforating branches, they accompany the anterior cutaneous branch of the intercostal nerve. In females, the perforating branch of 2nd, 3rd and 4th intercostal space are large and supply the breast. It gives the superior epigastric, it divides into the superior epigastric artery which runs behind the 7th costal cartilage between the sternum and the first costal side of the diaphragm to enter into the rectus sheath, where anastomose with the inferior epigastric artery. The musculophrenic artery runs laterally behind the 7th, 8th and the 9th costal cartilage, and it gives 2 intercostal arteries, one for every intercostal space. It pierces the diaphragm near the 9th space, and it supplies the diaphragm and the muscle of the interabdominal wall. If you see the histology of internal thoracic artery, the tunica intima has high endothelial nitric oxide synthase expression, which synthesizes the nitric oxide, which helps in the dilatation and prevents vasospasm of the artery. The internal elastic lamina is very well developed and it is not fenestrated. Hence, it prevents acts as a physical barrier that prevents smooth muscle cell migration and intimal hyperplasia. The tunica media, unlike other arteries, it contains fewer muscular fibers and a greater number of elastic lamella, typically 7 to 10 layers, which protects it from the atherosclerosis and vasospasm. The vasa vasorum is very scarcely distributed in the adventitia, and it limits the immune cell trafficking and further decelerates the plaque formation. The luminal wall is very similar to the native coronary arteries, approximately 1.5 to 2.6 mm. Physiological and biological properties, it produces a nitric oxide from the endothelium, and it helps in constant vasodilatation and prevents antithrombotic protection. It has excellent atheroresistance even when there are same risk factors such as hypertension or smoking. It has adaptive remodeling, a unique ability to remodel and increase its diameter and flow capacity over time to meet the metabolic demands of the heart. Harvesting technique, it can be harvested as a pedicle or an end block, where it is harvested along with the 2 veins and surrounding fascia and the muscle. Advantage, it is technically simple, and since we are away from the vessel, it provides protection to the vessel. However, it leads to shorter graft length and it reduces the sternal blood flow, which may increase wound infection in high-risk patients. Other is the skeletonized technique, where the artery is dissected individually and separated completely from the surrounding fascia and the vein. So advantage is that we get a longer conduit, approximately 1 inch more, and is excellent for sequential grafting, and also preserves the sternal microcirculation. Hence, it is better than the pedicle method. However, it is technically difficult and there is risk of direct injury to the lemma. Other is the semi-skeletonized method, where the lemma is harvested along with the veins accompanying it. If you see the patency rates, 1 year patency is 95 to 98%. Initial 1 year failure is mostly because of the technical errors in the surgery rather than the issue of the lemma itself. At 5 year, the patency is 88 to 95%, which is excellent compared to the other conduits. At 10 year also, the patency rates are 85 to 95% and excellent long term patency, and is highly resistant to atherosclerosis. We'll come to radial artery. In the radial artery was radial artery was introduced in the 1970s by Alan Carpenter and colleagues, where they performed the aorta to coronary anastomosis. However, they faced initial years of failure, and which led to abandoning of the procedure. However, after nearly 2 decades, the artery was again it was revived back. In 1989, Carpenter encountered an angiographic follow-up of a patient from early 1970s, which showed perfect which showed perfect radial artery patency after 14 years. Akar's reintroduction in 1992, Akar and associate demonstrated many occluded graft from the original series were actually to be found patent even after 18 years. They reintroduced the radial artery into the clinical practice, achieving better early patency rates through improved harvesting technique and pharmacological antispasm protocols. Today is a modern evolution and refined technique where we use the antispasmodic protocols such as use of calcium blockers, diltiazem, verapamil, and vasodilators such as NTG during and even in the post-op period to prevent spasm. The harvesting technique have been refined using the no-touch technique as well as use of the endoscopic harvesting. And there is importance of target stenosis, where the best results are achieved when there is high grade stenosis, approximately more than 70 to 90% stenosis. It minimizes the competitive flow of the native vessel. If there is less stenosis, it causes competitive flow, and the artery in the long term may look like a string sign. Radial artery originates in the cubital fossa, just middle to the biceps tendon, where it divides into the radial ulna from the brachial artery. In the upper arm, forearm, it is deep to the brachioradialis muscle. In the middle forearm, it lies next to the superficial branch of the radial nerve. In the distal forearm, it becomes superficial, lying between tendon of the brachioradialis and the flexor carpi radialis. In the wrist, it passes laterally along the wrist into the anatomical snuff box, and then again becomes superficial and palpable. In the hand, it enters the palm to complete the palmar edge. So radial artery, there is the rule of two. There are two muscles related to it: the brachioradialis, the flexor carpi radialis. Two nerves, superficial branch of radial nerve and the lateral antebrachial cutaneous nerve. And the limit of dissection is defined by two arteries: the radial recurrent artery and the superficial palmar branch of radial artery. If we see the histology, the intima is lined by a single layer of flattened endothelial cells. It has a wavy and fenestrated internal elastic lamella. The tunica media is the thickest, having multiple layers of smooth muscles. The tunica externa or adventitia is irregular, having connective tissue of containing collagen and elastic fibers, and occasional vasa vasorum. So, advantages of radial artery: it has long-term durability, much better than the venous graft. It is easy to harvest, can be harvested concurrently along with the internal thoracic artery, and it's suitable for patients who are diabetic and obese individuals, where bilateral intrathoracic artery harvesting can lead to sternal complications. Lower rate of infection, or lower rate of sternal wound infection. Good physical properties: it has adequate length, diameter, and a muscular wall which is adaptable to the arterial pressure. And versatile, it can reach almost any coronary artery over the heart surface. Disadvantages of radial artery: since there is a thick muscular wall, it is very prone to spasm. It can be prevented by using of medications such as calcium channel blockers. Requires good circulation. Before harvesting, we need to confirm the collateral circulation, the patency of palmar edge by the Allen's test. It can lead to hand complications such as hand numbness, weakness, or rarely ischemia if there is injury to the nerves. Competitive flow can happen if the severity of the blockade is not very severe. And in post-catheterization, post-cat patient, we should practically avoid use of radial artery as a conduit. And harvesting issue, the risk of nerve injury during harvest, and there is a side potential for scar and cosmetic concern because thoracic, internal thoracic and the vein are usually covered under the clothing, whereas the radial artery scar can be visible over the hand. So before harvesting radial artery, we need to perform the modified Allen's test, where the radial and the ulnar artery both are pressed and see the blanching of the arm, and the ulnar artery is released, and we see again the hand returns to its normal color, which suggests it is a positive Allen's test, that is the Palmer arches pattern. It can be performed better with the use of spo2 probe, where we can see the spo2 waveform and perform the modified Allen's test. Radial artery can be harvested either open technique, where a skin incision is placed along the forearm, or can be harvested endoscopically with a minor incision, and carefully the artery and the branches are dissected, preventing any spasm and gentle handling throughout the procedure. For management of the radial artery spasm, intraoperatively we use the no-touch technique, where we stay away from the radial artery. We do not touch the radial artery or the veins accompanying it. Use of harmonic scalpel. Use of organ bath for storage, where 30 mg papaverine in 30 ml heparin saline is made, and the radial artery after harvesting is kept inside this organ bath. Use of hydrostatic dilatation. Gentle interluminal dilatation using antispasmodic has been done through small vein cannula placed inside the radial artery. And for long-term prophylaxis, we use calcium channel blockers, amlodipine especially, nitrates, isosapide mononitrate, or use of nicorandin. Patency rate, 1 year patency is 80 to 99%, and some study shows that there are very high initial rates up to 99%, and there is a revival phenomena where the graft which initially appeared narrowed or string sign shortly after surgery become fully functional within a year as they adapt to the coronary circulation. The 5-year patency is 83 to 93%, which is almost comparable to internal thoracic artery, but much better than the saphenous vein. And 10-year patency rate is 83 to 89%. Just to, as a part of the discussion, the gastroepiploic artery, which is not practically used, but we'll just go through it quickly. Target selection, it is more suitable for distal RC or PD anastomosis, and there should be severe stenosis of more than 90% to prevent graft failure. Its advantage is that there is aortic no-touch technique, where since we use the in situ graft from the abdominal wall, there is no manipulation of the diseased or calcified ascending aorta, and hence it helps to prevent stroke. It is used for redo CABG, where no conduits are left, and we can harvest the epiploic artery from a practically virgin area. If you see the surgical characteristic, it is a branch of the gastroduodenal artery and it runs along the greater curvature of the stomach. It is vulnerable to spasm, and hence the use of intra-op and post-op calcium channel blocker is must. And it is harvested as a technique. It is a skeletonized technique, where the branches are clipped and the whole pedicle is flipped up and used for anastomose at distal RC or PDA. And it's a unique biological response where there is increased blood flow after meals due to histamine-induced dilatation, a physiological adaptation to its original role in stomach blood supply. Outcome and patency. So patency rate is poor, around 66 to 70%, and there are some studies which show higher patency rate of almost 90% at 8 to 10 years. And the complication is, although we are entering the abdominal cavity, studies show there is no significant increase in the gastric ischemia or long-term abdominal complication. Inferior epigastric artery, very limited use, practically not used, reserved when conventional conduits are not available. It is harvested from the anterior abdominal wall by paramedian or phalangeal incision, and it is used as a Y graft. It is prone to spasm and shrink and has poor patency rate. Now we'll discuss the saphenous vein. The great saphenous vein originates in the foot where the dorsal vein of the big toe merges with the dorsal venous arch. It passes anterior to the medial malleolus and ascends on the over the medial aspect of the leg. It lies posterior to the medial condyle of the femur and the medial border of patella, ascends into the thigh, into the saphenous compartment, and it terminates through the saphenous opening into the fascia lata, joining the femoral vein at the saphenofemoral junction at the groin. If we see the histology, the tunica intima is very thin and is separated from the tunica media with rudimentary subendothelial layer. The tunica media is very thin. It has outer circular layer containing collagen fibers and the inner longitudinal layer which has few elastic fibers which continues as the valves of the vein. The tunica adventitia is the thickest layer uh, composed of primarily collagen and elastic fibers which provide structural integrity and anchor the vein to the surrounding saphenous compartment. So advantages of saphenous venous conduit: accessibility and abundance. Easily accessible in both limb and helps to when there is need of multiple graft are required and to reach any coronary target. Technically easy because it's of large diameter, has robust wall characteristic which makes it technically easier to handle and anastomose compared to the smaller arterial conduits. Resilience to spasm intraoperatively, just contradictory to the radial artery which is very prone to spasm. Resistance to competitive flow, the patency is less affected by the competitive flow of the native artery. So even if the stenosis is around 60 to 70%, it has a superior resilience to competitive flow. The saphenous vein is less affected by competitive flow from the native artery, making it superior choice for bypassing a moderately sinuous vessel with like 60 to 70% stenosis, and reduce patient risk since we are harvesting from the leg. There are no risk of wound infection, deep sternal wound infection. Disadvantages: it has inferior long-term patency rates. We'll see in the further slides. It has accelerated atherosclerosis. Even when the vein is patent, there are sites of intimal hyperplasia and accelerated atherosclerosis at multiple sites throughout the vein. Surgical trauma during harvest. The traditional harvesting technique often leads to damage of the veins adventitia and vasa vasorum, which can lead to early graft failure. Leg complication such as infection, hematoma present, but that is practically easier to manage. It does not secrete nitric oxide or prostacyclin like the arterial graft. Contemporary mitigating strategies: use of no-touch technique where the pedicle is harvested along with the fatty tissue around it, which maintains the vein structural integrity, has shown long patency rate comparable to arterial graft. Use of endoscopic harvesting also reduces wound complications and maintaining similar outcomes. And use of external sending, we'll see in the further slide use of the external sending and how it reduces the intimal hyperplasia. So harvesting can be a conventional open technique where a long incision is placed along the skin incision and the vein is stripped off from the surrounding adventitial layer and the side branches are ligated, and it is often multiple times distended under high pressure to overcome the spasm before implantation. Or it can be done by similar thing can be done using small skip incisions. The use of no-touch technique where the vein is harvested like a pedicle of 0.5 centimeter surrounding the perivascular fat and keeping the perivascular fat and the tissue intact. The vein is not manually distended with high pressure and it is gaining popularity as a biological stent. Use of endoscopic vein harvesting where a 2 centimeter incision placed near the knee, an endoscope is used to create a tunnel using CO2 inflation. It is dissected free from the surrounding structure and the side branches are ligated during bipolar contraction. Patency rate, Early 1 week to 1 month, 85 to 95%. Early failure is due to technical errors or acute thrombosis. 1 year patency is 75 to 86%. 5 year patency is 70 to 80%. 10-year patency is 50 to 60%. And long-term 15-year patency is less than 50%. So the factors influencing vein patency: harvesting technique. The no-touch technique has better patency, long-term patency rates. Target vessel, anasmosing to LAD has better patency rate as compared to the RC or the circumflex. Caliber vessel, native vessel of larger size more than 2 mm has better patency compared to the lower smaller native vessel. Use of sequential graft has better patency due to better flow velocities, and there is need of statins and aspirin for vein for long-term patency. So if we see saphenous graft failure, the early failure is because of acute thrombosis within 1 month, primarily due to mechanical and biological triggers which had happened during the surgery. So there will be endothelial injury because of harvesting techniques where it is the strip and high pressure distension is used. It causes the endothelial denudation. This activates causes the prothrombotic shift where the loss of the endothelial layer reduces the production of nitric oxide and prostacyclin and exposes the basement membrane, which causes activation of the extrinsic pathway where activates the external it activates the external coagulation cascade and causes platelet aggregation and fibrin deposition. Technical errors such as grafting, overstretching, or poor distal runoff also affect the early patency. The next is the intermediate phase of intimal hyperplasia from 1 month to 1 year. In this phase, the vein goes through arterialization, where the vein attempts to thicken its wall to withstand the arterial pressure stress. It undergoes phenotypic switching, where the vascular smooth muscle cell in the medial layer switch from a quiescent state to a synthetic state. This synthetic state causes proliferation and secrete extracellular matrix such as collagen and the elastin, which causes the wall thickening, and gradually it causes the luminal narrowing. And the cytokine release such as PDGF and interleukin 6 activate platelets and leukocyte driven process. It causes spasm and platelet aggregation. The late phase of graft failure, more than 1 year, is primarily because of the atherosclerosis. There is neoatherosclerosis, plaques develop on the foundation which was ultimately laid by intimal hyperplasia. There is rapid progression. The atherosclerosis of the vein is typically more concentric, diffuse, and friable compared to the native coronary artery. Vulnerability: these plaques often lack very well-developed fibrinous cap, and hence it is more vulnerable to thrombotic occlusion. Inflammatory infiltration, contained recruitment of the macrophages lead to formation of the foam cells and further destabilizes the graft wall. The use of external saphenous vein support. It is a highly flexible, semi-compliant, kink-resistant tube made of nickel. It is like a sleeve which is placed over the vein, and it serves the following purpose: pressure management. It prevents the vein from over-expanding when it is exposed to high pressure arterial blood flow. Diameter matching. It downsizes the vein by approximately 35%, creating more appropriate size match between the vein and the native coronary artery. And it prevents the intimal hyperplasia by reducing wall stress. It is intended to mitigate neointimal hyperplasia, which is a major cause of long-term vein graft fluctuation. To end the rest of discussion with the rest of the conduits, we have the synthetic and bioengineered alternatives. The EPTFE graft or the Gotex graft, they show poor long-term patency because of gross mismatch of the graft and the native vessel and leads to thrombosis and intimal hyperplasia. Dacron graft Again, it has poor patency rates. Use of human acellular vessel, which is a bioengineered technology where human vascular cells are grown in a polymer scaffold and then decellularized to leave only the non-immunogenic collagen matrix. The early results are safe, and however it is not extensively used now. Tissue engineered vascular graft, they represent a developing field where stem cells and biodegradable scaffolds are used to create living conduits that integrate with the host tissue. Non-autologous biologic conduit such as umbilical vein graft, they are preserved in the glutaraldehyde and used as off-the-shelf option when other conduits are not available. They are elastic and readily available but carry risk of immunogenicity and calcification. Cryopreserved allograft, these are human donor vessel, often the saphenous vein graft, which are frozen for a later use. They are primarily used as a last resort and it has poor patency rate. So that's all for the conduits used in CABG. Thank you.